wasting so much time, look at the gender distribution. It's so obvious from this gender distribution that the men are taking more or are having more of these diseases. As at the 31st of May, we had about 6,882 cases. But I just want to bring up something quickly without wasting so much of our time to make us understand. The ratio of men to women as at the 15th of April was actually 1 to 0.6. The ratio as at the 30th of April was 1 to 1. The ratio as at the 15th of May was 1 to 0.82. And the ratio as at the 31st of May was 1 to 0.92. Also, in making us understand more about this analysis, we're trying to confirm what's the growth rate, how is the number of tests being carried out by NCDC, how is this growing? And from our analysis, we're able to find that look, sincerely, the NCDC is doing really much, and we must sincerely commend them, even though we know they could do better. But I must sincerely say that we commend NCDC, because if you look at from this graph, it shows that the total number of tests has grown at a cumulative average growth rate of 532% as at the 31st of May 2020. Now, if you look at the 15th of May and the 31st of May, it shows that there was about 100% increase, almost about 97% increase in the number of tests as at between the 15th of May and the 31st of May. So sincerely, I must really commend NCDC for this wonderful act, and we hope that they keep going at this. And without wasting so much of our time, finally, we looked at the total number of deaths compared to the confirmed cases in Nigeria. On an average, based on all this, you'll find out that Nigeria has an average of 2% deaths compared to our confirmed cases. So I want to tell a lot of people, look, we need to relax. We should all relax and be fine, because if we look from the figures, this has been able to show us that, look, 2% is fine. So at this point, I would love to hand over to Dr. Abimbola to carry on and give us the Lagos presentation. Thank you.
Thank you so much. Good afternoon, everyone. And you're welcome to this webinar. Next slide, yes, next slide. My name is Bowale Abimbola. I am the Medical Director of Mainland Hospital, Yaba, and also the team lead for case management in this outbreak. So I'm going to talk about the containment approach by Lagos State and the lessons that have been learned. Next slide, please. Basically, in 2014, when we had the Ebola virus disease in Lagos, a lot of things weren't available then in the hospital. So, but a lot of lessons were learned from that, and certain things were now put in place. One is infrastructure. We didn't have an isolation centers at that period, so we had to use what was available for the treatment of drug-resistant TB. And we had to move those patients out and then move in patients. But as of today, isolation infrastructures were available on site in mainland hospital, ready for this particular outbreak, because we knew that a disease is going to come and then there could be a large outbreak. So mainland hospital was designated by the state government as a center for the treatment and then for the control of this, of any infection or of any outbreak that we might have. And apart from having isolation centers, a BSL-3 laboratory was also built in conjunction with the Canadian government. And that BSL-3 laboratory is supposed to, one, help in rapid diagnosis, in the containment of the outbreak, and then also to act as a biobank. So that was established, and then it was readily available for use when we had the first patient that was brought to us from Ogun State in February 2020. Manpower development is also a very key issue, and prior to now, or prior to 2014, we didn't have any manpower that could be readily deployed for the containment activities. And so when we had the first case of Ebola in 2014, a lot of us actually didn't want to participate in the management of these patients. People were going to other pillars, social mobilization, media arm, IPC, epidemiology, but for case managers, it was a strange disease and nobody understood what it means. And then we didn't have any experience. But as of today, we have a lot of experience that we had learned from that. And some of our staff were also part of the contingent that went to Sierra Leone and Liberia when we had Ebola in 2014. So infrastructure was important. Manpower is also something that's important. And then prior to our first patient, the Lagos State government established the Lagos State Incident Command System, where the Mr. Governor happens to be the incident commander himself, and the Honorable Commissioner of Health for Lagos State happens to be the Deputy Incident Commander. And the essential pillars of that structure is what I've listed here. We have social mobilization, who are supposed to go into the community and educate our people of what this disease actually means, and then what they ought to do. The media arm is also the case manager, which I belong to. IPC is infection prevention and control. We have epidemiology and surveillance that follow up with, that do contact tracing and follow up. We have the laboratory service, which is actually very important. They make diagnosis and all that. So next slide is just a trend of what the cases we have in Nigeria and Lagos as at 4th of June. In Lagos, as of today, we made a diagnosis of more than 5,000 cases, and we've been able to admit about 1,800 or so. So, and the death rate has been very low, essentially, for us. Ensuring the safety of health workers is something that we take very importantly. A lot of fears were entertained by health workers, in terms of, because this infection is respiratory droplets. Will I get infected? Will I not get infected? So we ensure that we had adequate training for our health workers. We ensure that the IPC and case management works together. We ensure the provision of adequate personal protective equipment and the rational use of these equipment. Insurance cover was also made available to every health worker in the front line, so that in case of any eventualities, something will be made available. Hotel accommodation was also made available for everybody, all the health workers, so that in case you contract the infection, you don't take it to members of your family. And then we have well-equipped isolation centers. Our isolation center were basically, we started with mainland hospital, but as of today, we have several other isolation centers scattered all over Lagos, 6 extra ones. And in the next few days, we are going to open a 150 bedded isolation center in mainland hospital. So as of today, we have about 600 bed space for isolation. And then, as I've said, an additional 150 will be added pretty soon. Management of persons affected. Basically, once your diagnosis comes out positive, your result comes out positive, what we do is to isolate you so that you don't infect other people. And what we found is that a large majority of positive cases are actually asymptomatic or with mild to moderate symptoms. Only about 3% comes in with severe acute respiratory distress, and then we need ICU services. So basically, all patients are triaged, and then appropriate medication is given. This includes antiviral and multivitamins, and then follow-up test is also done to ensure that before you are discharged, you test negative. And we discovered that for the average person admitted, the average number of days they spent on admission before clearance is about 12 days. As I've said, contact tracing is also done to ensure that the contacts of the patients are followed up properly, and then if they also test positive, they are also brought in so that the disease will not continue to spread in the community. Thank you so much.
Okay, thank you so very much. At this point in time, we'd love to call Dr. Olumide to please carry on with it, sir.
Thank you very much, and welcome to all our panelists and attendees on this call. It's indeed a pleasure to be part of this webinar. The way Nigeria has responded has been a bag of mixed feelings, so to speak. The COVID-19 pandemic has been an experience in leadership. It's been an experience in innovation, and it's been a deployment of extraordinary response from various states. So what we hope to do in the course of this webinar is to share what's been going on in several of our states. As you know, as policymakers, our commissioners need to balance the responsibilities of interrupting the transmission of COVID, the virus, and also minimizing economic disruption, which right now has been described as the fine balance between lives and livelihood. So we will spend some time discussing how our leaders from the front line have been able to make certain decisions in terms of lives. Several of those have been shared with us by Dr. Bowale from Lagos. But this discussion cannot be complete if we do not also see how this interfaces with decisions on livelihood. So without much ado, several of our panelists have been introduced earlier on, but I will just go straight on to Dr. Patrick Okundia, who's the Commissioner of Health in Edo State. Can you just very briefly tell us how Edo State has been able to respond to the pandemic? Dr. Okundia.
Yeah, good afternoon, Dr. Okunola, and good afternoon all. Hello, can you hear me?
Good afternoon, sir. We can hear you loud and clear, sir.
All right, thank you. I'm sure I sent some few slides. Okay, thank you. I'm going to run through this as quickly as I can. Of course, we all know that COVID-19, otherwise called the coronavirus disease, first and foremost is a global humanitarian challenge. Of course, because we heard that millions of people battling these viruses in different ways across the globe. And for us in Edo State, we are not in isolation. So we have our own share of this crisis. I would like to just briefly make this presentation based on just three headings. I would say pre-COVID and COVID, and what I think we should have post-COVID. Of course, pre-COVID, we'll talk about what our healthcare system was. We all know that COVID-19 actually, as a leveler, exposed everybody in Nigeria to the nature and the state of our healthcare delivery system. Was a sorry state. Of course, I've practiced medicine here for many years, and I could tell you for Edo State, the story has not been a good one. In a situation where primary healthcare system was practically non-existent, secondary healthcare system was collapsed, and of course, the tertiary institutions, we just be managing them from the federal government, who now takes the burden of handling all cases, primary, secondary, and all cases. And of course, they become very, very challenging. Of course, we know that successive governments in Edo State have made several efforts, but it ends up just scratching the surface. And to the extent that to the people, to healthcare workers, all hope was almost lost. You know, of course, the huge medical tourism situation, both internal and external. Our manpower shrunk greatly. Quackery became the order of the day. Strike actions all the time. And of course, training institutions were nothing to write home about. But however, this is not a campaign. But my governor came in 3 years ago and said they must do something about the healthcare delivery system. And he set up a lot of machineries in place. Health Summit was started the first 3 months of assumption of office. We have gone a long way addressing this healthcare delivery system with efforts at revamping a primary healthcare delivery system and secondary healthcare delivery until this year, the COVID-19 came. We are all aware of the history. For us in Edo State, we got the information of the first or the index case of this country on the 27th of February. And 2 things came to the minds of my government. We were seriously in apprehension. The states at that point were preparing to host the National Sports Festival. And of course, it became also important that the index case was an Italian. And of course, everybody knows that there is 1 out of 3 houses in Edo State has a relative in Italy. And so the fear was there, and we needed to do something very, very quickly. The governor quickly set up a task force that he chaired himself, and set up a technical working committee that was being chaired by the deputy governor. And of course, we had our first case on the 23rd of March. We needed to put a lot of facilities in place with the hope that we could still go ahead with the sports festival. And we set out to get our isolation centers and all the facilities ready. It was only in the process of inspection and touring of what we had, because we're already leveraging on the fact that Edo State was also in the front line of infectious disease response in this country, with the presence of the IRWA Specialist Teaching Hospital that is already known as a center of excellence for research and treatment for infectious diseases like the Lassa fever. That we leveraged on, but we needed to develop and expand these facilities. Of course, we decided to do a lot in putting our facilities in place. Our strategy was very strong, that we needed to create a strong governance, the leadership and coordination framework on a daily review of strategies was handled by His Excellency, Mr. Governor himself. We intensified all the risk communication messages. And of course, we come to Benin, like billboards everywhere to sensitize our people, stakeholders engagement. We made that a lot. And decisions taken, like I must put here, were scientifically and data-driven. And stakeholders were all carried along in this whole process. We got experts to design an epidemiological model and the projections of what we were facing. That drove a lot of the decision-making with regards to our response to COVID-19. The stakeholders, including churches, religious bodies, civil societies, organizations, associations, and other unions, were called in. And most of the actions and decisions of government were emanating from the suggestions and decisions that were reached at such meetings. Now, we also strengthened our surveillance activities. Of course, we have a very well developed contact tracers. Of course, this deputy governor is also jokingly referred to as the chief contact tracer because of their experiences with Lassa fever. So this went a long way in sensitizing the people and getting ourselves ready. First, we needed to identify the facilities we had in place. Though we had like 4 facilities in place, 1 at each senatorial district and 2, of course, 2 in the state capital. But we needed to expand. At the least, the first we had at the Stella Obasanjo Hospital were a 12-bedded center at the Stella Obasanjo Hospital. Because of the scientific approach, we knew that will not go anywhere. So for the very first time, the governor said, let's expand, build another facility. A 30-bed isolation center was built just close to that one. Within 12 days, the structure was already in place and started equipping with all the gadgets we could think of. Oxygen concentrator, ventilators, mobile digital x-rays, dialysis machine. We got everything in place. Of course, we decided to also develop the other centers from the 3 senatorial districts. The Edo North, ACIOE, we had a center there, was now expanded as well. But going forward, the state government also decided to also expand the facilities at the federal institutions, the University of Benin Teaching Hospital, who before that time only had a 10-bedded facility for isolation, and the state has built a 35-bed isolation center. We also did that for the ERA Specialist Teaching Hospital, and of course, for the Central Hospital, ACIOE. But when we got to a point where we needed to see, the issue was that of testing. And testing was a challenge, not for only Edo State, but to the nation itself, where there were limited facilities for testing. But Edo State was being considered as a blessed state, being one of the initial 3 states with a molecular PCR machine. But we were not satisfied with that. We needed to test our people. So we went further to procure 2 extra PCR machines.
Hello, Dr. Okundia.
Yes, yes, please. Hello.
Yes, there's so much to talk about. We will still do a deep dive into some of the things you're talking about. So let's please hold your fire for now. Let's move on to other panelists, and then we will come back to explore further some of those important things you're talking about. I think at this point, I would like to call on Dr. Tomi Coker, Honorable Commissioner of Health, Ogun State, to also just briefly share with us how Ogun State has been able to fight this pandemic. Dr. Coker.
Good afternoon, everyone. Well, Ogun State had a unique position in the fight against this pandemic because we had to respond and prepare at the same time, given that the index case on the 27th of February was in Ogun State. Although he was transferred to Lagos, which was then the designated referral center, we got into action and activated our EOC, which had the 7 pillars, which my colleague had mentioned earlier on. I'm not going to repeat it, my colleague from Lagos State. But the key thing, because we're talking about lessons, practical lessons learned, we had to have an agile leadership, because to be preparing and to be responding at the same time meant that you had to have focused, collaborative leadership. We made sure that we leveraged on all our network, our relationships and our partnerships. So we collaborated with the private sector, which was at the time the industry where the first case was discovered. And one unique thing that I think was a key strategy and success point was the fact that at that industry, the contacts of the first, the index case, were actually isolated in individual rooms. They were not allowed to go into the community. So we were able to delay our community spread for a long while till about April. So for a long while, our R was 1. And we didn't see that escalation. We had clusters up until middle of April. We knew exactly what, where our cases were coming from. There were clusters. There was a particular family in a particular local government, which was at the center of Ogun State, Ikene in particular. There were about 50 members of that family that were positive. So that was a large cluster for us, but we knew where everyone was. We were able to contain them. And so with that, we were on top of our cases for a very long time. But saying that, we knew we couldn't fight it as a state alone. We actually collaborated with the private hospital, the tertiary centers, and also the Federal Medical Center in Ogun State, because we wanted to respond not as a state government, but as a holistic state. We then we set up our isolation centers. We had the strategy that We want to be preventative mainly because looking at the infrastructure, the health system that we had, we knew we stood no chance if we had to be curative. So we were very proactive in being preventative. The risk communication team were out there. We had timetables for media engagement on a daily basis. We set up rapid responding team in every local government. The 20 local government had a rapid response team, which included disease notification officer, medical officer of health, and all that helped us to decentralize at a very, very early stage. Having said that, the second strategy for us was also, we looked at our past and we knew that our IGR was nowhere near the neighboring states. So we became quite innovative early. By the first week of the outbreak, we were manufacturing our own sanitizers, we were manufacturing fabric face masks in our hospitals for non-essential, healthcare workers like the gatemen and the cleaners, because we wanted to conserve our funds for the essential equipment that we knew we were in deficit of. So we did that. And by the time we set up our isolation centers, we looked around, we were conscious not to use temporary buildings and facilities. So we went into our health system looking for projects that have been abandoned and also to strengthen our health system. So we found a general hospital that was an infectious disease center previously that had been abandoned. We strengthened that and turned it into a 75-bed isolation center. We found an abandoned model school that gave us a 128-bed isolation center. But more importantly, we had an isolation center which was co-located with the teaching hospital in Olabisi Onabanjo Hospital, teaching hospital, which was a 18-bed isolation center. Initially, we were upgrading it for Lassa fever, but immediately, because as you know, we started off with Lassa fever the first month of the year and subsequently rolled into coronavirus. So as we were renovating, we modified it, ensured that it was IPC compliant, and the flow of patient was actually commended by the WHO. We quickly used our resources in a very, very clever way, and making sure that each Naira went a long way by actually becoming self-reliant, finding things that we could do on our own, manufacture within the state, and then importing the things that we couldn't manufacture. We have been able to strengthen our system with all the equipment, mobile x-rays, ultrasound, dialysis machine, and all that to support any patient that deteriorates. But our story is different. The picture is different in Ogun State in that we have 99% of our patients are asymptomatic to mild. So far, out of 317 patients, we've only had to administer oxygen to 2, which gives you less than 1% rate of critical cases. And another thing we realized, we're looking at a socio-economic is that we are in proximity to Lagos. Our economy is actually different to Lagos. It's based on agric and factories, and a lot of our citizens have to go out daily to fend for themselves. So when we were mandated to have a lockdown, we actually moved our lockdown deliberately for a week to allow our people to prepare, because we knew what the economic impact of that lockdown was going to be on our people. So we gave them that extra week to prepare themselves. And then when we went into our lockdown, we had our own version of a lockdown in that we had a respite every 72 hours. So every 72 hours, people were allowed to go out for about 6 hours to fend for themselves and then go back in. That, I believe, has helped us a lot, because our concern was that we didn't want a populace that was malnourished couldn't fight the virus if it actually, if we had a major outbreak. We've been fortunate, we haven't had that major outbreak, and our cases have been undulating. But round about sort of 10th of April, we started testing, 10th of May, we started our community-based testing, which then ramped up our cases.
Thank you, Dr. Coker.
Yeah.
Yes.
Okay.
Thank you. I think that's such an interesting story, one that I've heard before, but it's still very interesting to hear how your state was able to move quite rapidly to where it is today. Again, we do hope to have some time to unpack some of the things you've said. So we'll move quickly to Jigawa State. Sadly, we couldn't have the Honorable Commissioner in person, Dr. Abba Zakari, who is also is a four-time Commissioner of Health in Jigawa and currently the Chairman Commissioners Forum. But he is ably represented today on the panel by the Executive Secretary of the Jigawa Primary Health Care Agency, and who is also serving as the Incidence Manager of the COVID-19 response in Jigawa State. Dr. Kabir, can you share with us what and how Jigawa has been able to respond to the pandemic thus far?
Thank you very much, Chair and the lead of this panel. I hope I'm being heard as I'm speaking. Can you hear me?
We can, loud and clear.
Very clearly.
Okay, excellent. A very good afternoon to everyone. I think I will start with the second slide, which has given a summary of the the critical activities that have been conducted to address this pandemic. We started by establishing 288 beds as isolation centers, which were actually categorized into three. Level 1, which is taking care of all those asymptomatic patients who are the majority of the patients that we saw. And then we have a level 2 center that has 22 beds that's taking care of moderate symptoms. And then level 3 that has the ICU component. The ICU center is a 16-bedded facility, and it has all the modern gadgets for intensive care operations. While these 288 are in place, we still are optimizing another center, which is bringing another 122 beds, making altogether, about 22 beds, that's making the total number of beds available for isolation to 300. I think the major challenge that we've had in this operation was the fact that we are challenged by repatriation of almajiri, beggars, street beggars, those small children that beg with their plate in their hands from about 5 different states, including Kano, Adamawa, Taraba, Nasarawa, and Gombe State. And we had 1,348 of those almajiris that came in the middle of this pandemic. And that was actually the time that Kano was heating up with very, very high number of cases. So we felt it could be very dangerous to allow these children to go into the community to begin to become seed stock for transmission of COVID. So we quarantined all of them. We actually tested all of them over a period of time. And those that actually tested negative were set free, and those that were positive were put into the isolation arrangement. As I speak to you now, only 3 of these 1,340 almajiris are still in our isolation center who are still positive and are yet to convert. We have also leveraged on a concept of Jakarta Life Here is Health Ambassador. These are community focal persons where we have one in each of the 12,000 communities that we have in Jigawa State. This structure was actually at hand even before COVID comes. So we leverage on it where these community people were mobilized for contact tracing and also reporting of suspected cases. We've had a number of returnees from Lagos and other southern part of the country, some of these Okada riders and a lot of manual workers that were actually populating many southern states that were from far north. A good number of them actually from Jigawa. So when they are coming from areas that were heavily in high endemicity situation, we had to also quarantine them and test them and all that. So these community people really play some role in doing that. We have also put in place palliative that took over, oversee provision of support to over 100,000 families, and this is still ongoing. Because we had challenges in terms of waiting time for results, the nearest molecular laboratory that we had was in Kano, and the turnaround time was pretty more than 2 weeks in the beginning of the operation. So we actually mobilized a molecular laboratory and installed one in Jigawa State. And as I'm speaking to now, the lab is in full operation. The people from NCDC are on their way to Jigawa today to come and provide certification for that laboratory. But in the meantime, we run tests this lab, and then we take samples from the same samples to CDC certified laboratory to confirm what this laboratory has done. And when they concur, we take decision. The other thing that we also done was the establishment of, we are looking at the possibility of zonal testing sites very far away from the state capitals to allow community testing to happen so that we be in front of this pandemic. We have also deployed 9-member medical and security team in all the 22 entry points that we have in the state. In addition to that, we've trained nearly 2,000 health workers at different levels, 1,421 primary healthcare workers, 390 staff from the general hospitals. We have also put in place 9 teams for rapid response team at the state level and 27 teams at the local government level. We've had 5 ambulances that are meant for evacuation, and they're all equipped with evacuation team members. We've also mobilized a burial team in case we had some incidents, and we had a couple of them as we speak. So I think with this, we'll go to the last slide. I think that's where I have the summary of the things that happened. In total, we have screened, we have tested over 2,000 suspects. And like I said, 60% of this number are actually the Almajiris that were repatriated from neighboring states. Out of this, we have 274 positive cases to date, of which we have discharged 222. We still have 44 in our admission. We have 8 deaths. But this 8 deaths, we had 3 deaths that took place in our isolation center, but the other 5 were actually at community level before the patients, before the result was actually reported back to us. That was actually the time that we had a very long time when we take samples, and the result is actually in Kano before it comes back. It takes 10 days, 8 days. So, I mean, this 8 days actually occurred before we could see results. But now that we have this laboratory in our hands, the turnaround time is much smaller, and we never had this kind of issue again. And so you're looking at this, you see the ratio between discharged and confirmed cases was 81, meaning that 81% of the patients that were actually diagnosed as positive were finally subsequently discharged. And if you want to look at the ratio between deaths and those confirmed cases at 2.9, this actually includes the 5 deaths that happened in the community before we could see their result. But if you want to limit this to the deaths that actually happened within the isolation centers, we're talking about 3, and so the ratio is virtually 1.8, 1.6, substantially less than 2.
Thank you so much, Dr. Kabir.
Thank you.
Thanks a lot. Thanks a lot. There's so much information out here. Thus far, we've had 3 states. We started with Edo State, we've moved on to Ogun State, and then Jigawa State. What have we heard so far? I mean, there are a few things that stood out clearly for me. In all cases, apparently, our healthcare leaders were able to engage fully with the political leadership. Because if you don't do that, you won't be able to get the kind of funding you require. I think the 3 speakers spoke eloquently to that. We also heard how this was used. The pandemic is also serving as a way to reboot the health system. So rather than invest in temporary infrastructure, our leaders are using this to rebuild the health system. As we just heard, now Jigawa has a molecular laboratory. And perhaps this would then be a good way to take some time and expand on the issue of COVID-19 testing. As at today, from my own data, Nigeria has only conducted about 74,000 samples. I need not compare this to what some other countries have done. I think one of our presenters earlier on showed a 500% rise in the number of samples tested, which is a great thing. In fact, as at February 2020, Nigeria had just about 2 to 3 molecular labs as at today, we're talking between 22 and 27, all in different processes of being accredited. We just had Jigawa. So and hopefully by the end of next month, almost all Nigerian states will have a molecular lab. This is not something we should take for granted. So a deep dive into testing. I would want to ask the Honorable Commissioner of Health, Lagos State. We've had a presentation from Lagos. So, but I would like this segment to focus on testing for COVID-19. And it seems that Lagos was one of the states that took its fate into its hands, even though I believe that Lagos has also started planning for this well before COVID hit. So, Professor Abayomi, could you tell us how Lagos has been able to scale up and expand testing for COVID-19, and what can other states also learn from what you have done? I suspect Professor Abayomi is muted.
Hello.
We can hear you, sir. We can hear you, Dr.
I'm on now. Okay, could you not hear me before?
No, we could, Prof. We could, Prof. So sorry, sir.
You could hear me?
Loud and clear, Prof.
No, I said, could you hear me before?
No, sir, we couldn't, sir. But we can now, sir.
Okay, okay. All right, good afternoon.
Good afternoon, Prof.
Yes, would you? Sorry, I was at a press briefing, so and it went on a bit longer than usual. So I'm at your disposal now.
Thank you so much for that, sir.
Yes, Prof, we wanted you to share with us how Lagos has done in terms of testing specifically. Dr. Bowale has shared with us how Lagos has dealt with the pandemic in a holistic manner, but we just wanted to have a deep dive into testing for COVID and how Lagos has been able to respond to that in particular.
Okay, do you want me to speak specifically about testing or in general?
Testing.
Okay, so, well, you know, Lagos was already building its capacity for testing before COVID-19. You know that the test is a molecular test. It's not an ordinary test. It requires a specialized laboratory, and it requires specialized staff. And of course, the reagents we use in the what we call the PCR test is very specific kinds of reagents that are designed to identify the virus specifically and give you a 100% accurate test. So we are already building that capacity before COVID-19 as a result of what happened during the Ebola outbreak. And then when COVID came to our shores, we started to expand our testing capacity. So initially we were doing less than 100 a day, and then we've increased to between 200 and 300. And in the last month, we've increased our capacity to almost 1,000 tests a day. That means that although we're not testing 1,000 a day, but we have the capacity to test 1,000 a day. And that's the reason why you can see Lagos every night. You can see Lagos results are just getting higher and higher, and it's a result of testing. You know, the more you test, the more you'll find. Since we're in a phase of active community transmission, you will naturally have if I test 10 people, I will only find maybe 2. But if I test 100 or 1,000, I'm going to find 20 or 200 because the virus is in community. So, Lagos has been expanding its testing capacity for a long time. Now we are testing about 1,000 tests per week, per million. And we have when you look and compare that to the rest of Nigeria, the rest of Nigeria is testing about 350 per million per week. We are testing almost 3 times that number in Lagos. So when you compare the volume of testing we're doing in Lagos to the volume of testing done in the entire country of Nigeria, and we're testing 3 times more than the rest of Nigeria, we naturally will expect to see very large numbers of positives when you test. So don't be alarmed in the next few weeks when Lagos continues to escalate its testing capacity. Naturally, our numbers are going to go higher and higher and higher. It doesn't mean that we're losing control of the outbreak. It means we're identifying as many people as possible with the infection. And when we know you have the infection, it's easier for us to do 2 things. One is to isolate you either in a isolation facility, or secondly, isolate you at home. And then in the other instance, if we know that you're positive and we keep an eye on you, and then we can also monitor how you're doing. If you have a asymptomatic or mild disease profile, then you will naturally get better without any problems. But if you're progressing to moderate and severe, then we want to know about that earlier than later, so that we can start some treatment to stop you from getting to what we call the critical phase, where you are in a state of systematic shock from the virus. And that is when we will start to lose patients. So testing is very important. It gives us an idea of what's going on. It helps us to isolate patients, and it also helps us to identify people that are going into a more severe form of COVID-19.
Thank you so much, Prof. Thank you, sir. That was exactly the point we wanted to highlight. Now, Lagos is literally moving towards testing at an industrial scale. Like you said, you're contributing 3 times the testing rate compared to the national average, which is great. But we see that it's actually pioneered by who led the effort to go into PPPs to deploy testing. Dr. Coker, could you kindly share with us what motivated that kind of innovative public-private partnership? Because I belong to a school of thought that without leveraging the potential and available capacities in the private sector, it is impossible for us to achieve our testing targets. So what pushed that idea, Dr. Coker?
Thank you very much. At the very stage, about 3 weeks, 4 weeks into the pandemic, our tests was getting more prolonged because we had to transport them to neighboring states and wait for them to come back. They were as long as 8 days, 10 days sometimes. So my governor is here, our own testing BSL level 2 lab. But we ran a lab in Lagos that we could lease the lab. So we leased the lab, and that was installed as early as March. And that took a little while for NCDC to actually accredit. But in the meantime, we also got a donor who contacted us and said they wanted to give us a static lab. And I said to them, no, we don't want the lab to be static. We want it to be mobile. So they built us a mobile lab, which initially we thought we'll move it from one local government to the other, but then we realized that operationally that wasn't efficient. So we put it in a location which moved at any time. So it was just to decrease the, collection of the sample to getting the result time. At this point in time, our turnaround time is now like 24 hours and sometimes even shorter, because we now have the capacity to test for 600. Both are acquired laboratory, which is co-located in the teaching hospital where the isolation center is, and the one that is located in a central place in the capital. Between them, they can scale up to 1,000. The challenge with our testing then is the manpower to go out and sample individuals. And we're working on that. We had the visit by the PTF who, sort of encouraged us, and they said they would give us the support we need to increase our testing. We're our sampling rather. We're very aware of the paucity of the number of tests that samples that we take on a daily basis, but we do have the capacity to scale up. Hello.
Thank you, Dr. Coker. Just to close the loop on the testing, there's no point testing if you're unable to trace. Dr. Kabir, there's something I took from your slide, Jakadalafia. So in Germany, for instance, you have a group of people called contact tracers. I mean, in German, and that has been one of the things identified as supporting Germany's success in fighting the pandemic. Could you, in 1 minute, just tell us a bit more about Jakadalafia, Dr. Kabir?
Okay, thank you so much, sir. We said this structure was already on ground. We used the Jakada to deliver primary healthcare at community level. These are people who follow up defaulters in immunization, in nutrition program. They are the ones that are responsible for recording of birth and deaths in community. So every little society that we have, every community has one person that was actually engaged to the traditional leadership. So when this COVID operation came around, we look at them as potential source because every case will happen at a community. So you always hear them in the middle of the night calling you that there's somebody who returns from an endemic region and is coughing, has fever, is having difficulty in breathing. Please, can you come and assess and test him and so on? So we realized that they're doing a lot. So we quickly engaged them through the traditional arrangement, and they were mobilized and they were given appropriate information to identify the key signs and call for the attention of the rapid response team at the LGA and the state level. And after that, when we get somebody who is positive and we want to trace contact, these are people who know the nooks and crannies of where the patients are and their relatives. So they help us a lot in saying that, in fact, in addition to this person, this other person had contact with you. And they were really very helpful and handy in ensuring that we do not have transmission going at community level without it being detected. That's how we actually leverage. And there are over 12,000 of them that we're working with. And their all profile, we have their details, their numbers, their telephone numbers. We have a formulary that contains their details.
So the Jakada Lafia, they are part of the health system. They're like community health workers. So they not only serve as contact tracers, they are also armed with identifying influenza-like illnesses, amongst other things.
Yeah, they're not health workers. They are local people within the community who were mobilized. Yes, they're not health workers by training. They are normal people within the society. They were identified, mobilized, and were given some orientation at that level to participate. Yes.
Okay, that's pretty innovative. Thank you so much for that. Dr. Okundia, you mentioned the use of data and epidemiological models. So a lot of people, there are about four global models that are used. I'm familiar with Imperial College models. So which of the models have you been using and how has that been useful? Tell us that. Dr. Okundia.
Can you hear me, please? Hello?
Go ahead.
Oh, thank you. Thank you. Oh, I mentioned that at the very beginning, the governor was of the view that we need to have data and get some scientific push to our response. Of course, we got some experts, some public health experts, even from within and outside the country. We will use the SIR model, and this was just to help us with projections. And this also helped us with decision making. And with regard to all our activities, we worked with this data. And of course, it helps us in knowing that we need to improve our facility. Of course, the emphasis was on this facility, healthcare workers, the training of healthcare workers to get them ready to these confirmed cases come up in the large numbers. And of course, its models also helped us to place emphasis on screening and testing. It was as a result of these models that we realized we needed to strengthen our testing capacity that resulted in the need to get 2 more molecular PCR PCR that we'll be using. If you look at our records, that it took an average of 2 months for us to rise from the index case to 100 confirmed cases. But it took just 10 days by the time the screening and the testing started for us to rise from 100 to 261. So we are getting them in numbers because we are testing and because we are screening. The screening exercises involve the fixed screening posts on all facilities, both private and public. And of course, we scaled up to having mobile screenings across designated areas of the states in all the local government areas. Then we also scaled up to border post screenings. This screening is still ongoing.
I'm not sure if I'm the only one who cannot hear Dr. Okundia, but we seem to have lost Dr. Okundia.
Hello, can you hear me now? Hello? Hello? Hello?
We will come back. Dr. Okundia, we will come back to you. It seems your internet is unstable. Professor Abayomi, Dr. Okundia, we will come back to you.
Okay.
Professor Abayomi, just to close the loop on research, I know that Lagos State has a number of research work streams, including research on hydroxychloroquine. How is that going?
Thank you very much. We've got a very elaborate research agenda. We're looking at several parameters, and one of them is clinical trials. We obviously wanted to have an indigenously designed clinical trial. We thought that chloroquine would be a drug that is available, simple, it's been used for centuries. We're familiar with it, and there is enough evidence in preclinical science and studies that chloroquine is beneficial. Our planning to start the trial was stalled a bit by the announcement from WHO and the Lancet publication, but that just caused us to re-examine our position and re-examine the literature, but it didn't stop our resolve to carry out the chloroquine trial. And we're still going ahead, and in the next week or two, we are going to commence chloroquine, hydroxychloroquine, and a number of other trials. Thank you.
Thank you very much. Dr. Okundia, will come back to you now. There are about 4 questions to you on the use of antibody rapid tests. And I believe that that's one of the things you're using for your screening ahead of the molecular tests. What do you have to say on the use of what do you have to say about the use of rapid screening tests. There are about 4 questions around that for you.
Oh, okay. Thank you so much. Of course, at the very beginning of this outbreak, a lot of thoughts and plans were get towards the need to get the rapid test kits, especially when we also, against the backdrop that we had only one PCR machine, and in the states that was servicing basically the south states. And of course, turnaround time became an issue, and the time it took to transport samples from centers, from locations to the testing center. So, but we were also guided, like I said, by data. And of course, we got the directive from the NCDC on to be careful with the use of RODTs, especially against the backdrop that the level of sensitivity was not so reliable. So we have not gone to that extent of utilizing RODTs as our main method of testing. What's happened at the early stage, procurements were made with RODTs. These we have deployed to only border stations for screening purposes alone. And when we get cases that we confirmed as being suspicious, such a person who will now be sent for the molecular PCR machine testing. So far, it's not on the front burner of our testing devices. Thank you. Hello.
Thank you very much, Dr. Okundia.
Yeah.
So as we now begin to talk about case management, we saw the experience from Lagos and how Lagos is rapidly scaling up the availability of treatment centers. Professor Abayomi, with the number of cases that you're going to pick up and from the scaling up of tests, and we also saw from the data showed where you have 3% case fatality and just about the same number in terms of level of severe cases. What is the capacity available to manage such severe cases that would need hospitalization beyond those that will be managed at home?
Okay, so can you hear me? 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 Have you put another phone? Can you unmute? Can you unmute? Hello? 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 Hello?
If Professor Abayomi is having problems, we have a question for Dr. Coker. Dr. Coker, the protecting healthcare workers with the necessary consumables and protective kits would be essential. We have also heard on this call how some states are providing insurance cover. What is your experience with, or how are you dealing with the protection for your healthcare workers who are on the front lines day and night? Dr. Coker.
Thank you very much. As part of our way of actually showing that we value our health workers' commitment and the risk that they face, we were one of the first states that actually implemented a personal life insurance. As far back as the 5th of April, we actually procured life insurance for the 250 healthcare workers that we anticipated would be working in our isolation centers. And subsequent to that, we've also procured the same level of life insurance to the 8,000 healthcare workers across the state. So the people working in the isolation center get double life insurance, whereas all health workers get the one life insurance, because we recognize the fact that frontline worker, in that the patients that are suspicious, you don't know they are actually COVID positive until you've tested them. That has helped us a lot. We also provided what I call appropriate PPE, because if with appropriate IPC training, people will recognize that you don't need to have the whole suit on to be protected. The key thing is to have your mask and your gloves that would, and a face shield that would give you that barrier between you and a suspected case. That we've been implementing. We've had some agitation around being protected, in that people don't have the full understanding of when the suit is meant to be used. But I am grateful for the CDC guideline on appropriate protection, which came out last week, including what to use in clinical setting, in clinics. So we are on top of that. We're providing the appropriate PPE for the right clinical setting. Thank you.
Let's just read the file.
So it seems like, hi everyone, my name is Akin Abayomi. It seems like Dr. Olumide had some technical issues. So I want to go back to the question that was posed to Professor Abayomi. Good to see you again, sir. And if you could, I think you had some technical issues earlier on, but if you could just answer the question that Dr. Olumide posed to you earlier.
Yes, can you hear me now?
Very well, sir.
Okay. So I believe the question was around with the rising numbers of diagnoses we're making, we're likely to see more patients that require high care. And what are we doing around making high care more available to the expected numbers of patients that may require it? So as you know, we've been building isolation centers and opening new ones, and several private practice facilities are joining, corporate entities are joining the government COVID-19 response. So we're not stopping building our isolation centers, but we believe that with the trend, we're going to keep seeing a lot of positivity, especially the more you test, the more you find. And so in finding the positives, that really just helps us to isolate people and keep the graph as flat as possible. But generally speaking, there is community spread, and we expect the numbers of people who catch this virus to increase. And it's simple statistics. And if you have 3% develop severe to critical disease, then you have to make the availability for managing such cases. So by shifting a lot of our mild to asymptomatic patients to home-based care, we will create more space in our isolation facilities for higher care. And by recruiting the private sector that have access to high care beds and increasing our high care number of beds within the isolation facilities, that we'll be in a better position to manage patients who've developed either respiratory or renal complications of COVID-19. So we are upgrading many of our isolation facilities to higher levels of high care. We are equipping our ICU centers dedicated to COVID, increasing the numbers of beds all the time. We're training medical officers of health, senior nurses and technicians, putting them through crash courses in intensive care. so that as the numbers of patients go up that require higher levels of medical monitoring and oxygen therapy or dialysis, that we'll be in a position to offer that to our patients. And we're beginning to see some benefit to rescuing many patients that find themselves in that position. So it's a well worth exercise.
As the numbers go up, do you see a situation where there would be another lockdown? What if, all of this capacity gets filled up? Do you see at all in, say, 4 to 6 weeks?
No, so we've stated that in the next couple of weeks we're going to transition to home-based care. There's a limit to how many isolation facilities you can build, and at some point you reach a tipping point where you say, okay, we don't have any more institutional beds for COVID, so we're going to manage people in community, and we're preparing for that. So, if our numbers continue to escalate because of active community spread, then we'll manage those patients who are not complicated at home, and we'll reserve our isolation facilities for more complicated cases. I don't think that it's going to cause another lockdown, because we are just going to try and practice voluntary social distancing and good respiratory hygiene. And if you're positive, then you isolate yourself.
So you don't think there will be another lockdown? But then there's also another important health system question, Dr. Coker. With all the resources moving to COVID, what happens to deliveries, management of under 5 kids, contraception services? How are you dealing with that as a leader on the front line, Dr. Coker?
So being very conscious of the fact that there are other healthcare issues that are non-COVID, particularly in the primary healthcare center, where majority of our mothers receive their antenatal care and are delivered, and also the 0 to 5 get their immunization. We've kept our primary healthcare centers open throughout. We've run media campaigns to ensure that mothers are aware that those primary healthcare centers are open. And particularly, one has to be conscious of family planning issues, the number of unwanted pregnancies and the complications that might come out of that if pregnancy are unwanted, and the risk of illegal terminations and the complications of septic abortion. So we've kept our eyes on our primary healthcare centers. We've renovated 20 and we've equipped them, and we've really gone into our local governments and picked comprehensive health centers where people could go to and get tested for COVID, as well as segregate those healthcare centers from the ones that provide the routine day-to-day services around maternal and child health.
Thank you very much. Just staying with you, Dr. Coker. If there's a proposal to the governor, the Commissioner of Finance wants money for palliatives, and you also just submitted a proposal for additional financing for health, and we have to advise the governor. How do we do this? He has two competing proposals. How do we, because this is the kind of questions governors are asking like every day.
Well, there's the human, cost and the financial cost, and I don't think they're mutually exclusive. So if there is a proposal from myself and the palliatives, it's a balance in that healthy people that eat well will have a good immunity to fight COVID. So I would go with nourishing the people and also pushing on the preventative methods rather than the curative, where we're buying high-level equipment, CT scan and X-ray machines. Rather, if we can increase our sensitization, advocacy, ensure that people know the consequences of not having good personal hygiene, making sure there's free-flowing water, or all the mask, but as just as impactful.
Yeah.
And
thank you so much. You answered my question. Dr. Kabir, last word from you, Dr. Kabir.
Yes, I can hear you, sir. I can hear you.
Yeah.
Hello?
Your parting words. What?
Hello, can you hear me?
Dr. Kabir.
Yes.
Yes.
Okay. I just want to say people should be very aware of the fact that this pandemic is not yet concluded, and there are many lessons to be learned. There are emerging evidences and so on. We hope it's going to be a situation where we're going to use the COVID to strengthen our health system, because now governors listen very carefully when we say we want this, it's done already, and so on. Like, you know, we've gotten 5 ambulances within the span of a couple of weeks. These are opportunities that we can all leverage upon to strengthen our system as we also run through COVID operations. Thank you.
Dr. Okundia, over to you in 1 minute.
Oh, thank you, Olumide.
Yes.
I want to thank you for this opportunity and for the organizers of this webinar. I will just summarize by saying, to me, I think COVID-19 has been more of a blessing to the health sector, especially for my state, Edo State. It has given us the opportunity to have massive infrastructural reforms in the health institutions across the state. We've had training of healthcare workers and who, for now, have never been this motivated. A better reward system for health workers have been put in place. This has set the stage for those much desired restructuring of the health sector in Edo State. This is where my concern is. And I think my state governor has put the response on the right track, and we thank God for that. Thank you.
Thank you very much. Professor Abayomi.
Yes, sir.
Yes, sir. Your parting words for us on this webinar. Yeah.
Well, I think, basically Lagos is ramping up testing. Our data can look scary. I don't want the rest of Nigeria to be scared by the Lagos data. I think the more you test, the more you'll find the nature of Lagos is such that an airborne pathogen or a droplet-borne pathogen is easily transmitted. We're grateful that majority of patients have a low virulent disease. And so we're just going to keep doing what we're doing. We're going to test. Those are positive. We'll try and isolate one form or the other. And then we can try and rescue people who are suffering from a severe form of COVID-19 by giving them closer monitoring and oxygen therapy as required. Well,
Thank you very much.
We're still not peaked yet, but we hope that that peak will come soon. Thank you.
Right. Thank you. Dr. Coker?
My comments is that COVID-19, have to continue to think about how we can deal with it in the community and also deal with the other non-COVID issue to ensure that at the end of the COVID response, we're not left with other non-communicable diseases that we have to deal with that might challenge our health system, particular maternal mortality, which we've seen arise in. So thank you. We need to keep our PHCs open for those services. Thank you.
Thank you so much. Before I hand over to Akin, for me, I have 5 nudges that I've gotten from this webinar. First, scaling up testing. But you're not just testing, you're using the likes of Jakarta Lafia. That needs to be explored further. It's a great innovation, but testing can also be scaled up using private sector partnerships. We've seen examples in Lagos, in Ogun, that's been able to do this. You need to also look at research. If Lagos had not stayed the course, perhaps they would have stopped the hydroxychloroquine study, but it's still going on. You have healthcare workers enjoying a new lease of life. We've heard insurance being provided for healthcare workers, amongst other things. Akin, I'm over to you, and thank you so much to you and your team, Bami, for organizing such a wonderful webinar and having really, really interesting panelists on the call. Akin.
Good afternoon, everyone. This has been such a really fruitful discussion. Let me first of all start by thanking our distinguished panelists, the different commissioners, Lagos, Ogun State, Edo State, the representative from Jigawa. Thank you so much for taking time out of your busy schedules. I know we've had to go back and forth, but you accepted to be on this panel and participate, and we really, really thank you. So our moderator, Dr. Olumide, you've done a fantastic job. I received several threats here for you saying that you're cutting them short. So don't worry, we'll talk about that afterward, but thank you for a fantastic job. And for the different commissioners and different representatives, all your frontline workers, we commend every single one of you. It hasn't been an easy journey. It's the first time you're engaging in things like this, but you've done a really good job. I must thank you. I also wanted to add that this is our first webinar. We're going to move on to our next one, which next week, Friday, will be our next one, and our next health webinar will be on the 19th of June with some additional commissioners of health. And if you have any questions, send us an email at contact@acioe.com. Contact us at acioe.com. I just want to leave a final word and make a comment. One of the things that COVID-19 has brought to the limelight is the value of health, social impact, and education, especially girl-child education. I do believe that we all have a role to play, and what we do daily matters, whether it has to be to ourselves, or our family, community, and Nigeria at large. So what we would like to do is encourage key stakeholders in the public sector to become health and education champions. And as we focus on COVID-19, we appeal that to the commissioners and to your principals that they don't neglect the other pressing health issues and education issues at the federal level and even at the subnational level. We thank you once again for everything you've done. My personal quote is, and I believe, and I'll leave you with this word, is nothing is impossible to those who believe. And I will say this, people have been asking if we can do an extra 5-10 minutes, but that is up to the commissioners. If you can stay for 10 minutes, I mean, because they have all these burning questions, we would really love it, but if you can't, we'll understand. So I'm appealing to Dr. Coker, Dr. Abayomi, our commissioner from Edo State, and our representative from Jigawa. If you can just take one question each, even just 2 minutes, and Olumide, if you can just lead that. So at least we can just get an extra 10 minutes. That's if you have the time. We really appreciate it. So Dr. Olumide, over to you.
Yes, I'm trying to look at the questions online because several of them we've asked, so perhaps if there's someone on your own end there that if we have some of the questions that remain unanswered, I have the Madagascar question. If Professor Abayomi could say something about the Madagascar formulation, very briefly, what's his opinion about that? That's one question online. Professor Abayomi, Madagascar for you.
I can't say too much about Madagascar, but I can talk around the principle. We have a traditional medicine board in Lagos. We have a traditional medicine research committee. We're very keen to explore ethnobotany and the medicinal value of the ecosystem. So we are well established to analyze this product from Madagascar. In fact, I understand some of it is in Abuja. And we may get some in Lagos, and we will submit it to our research committee. The first thing about traditional medicine or herbal medicines is to, first of all, make sure it doesn't have any toxicity profile. You don't want to, as doctors, our mantra is first do no harm. So it may be potent, but it may also be toxic. So we first must establish that it's not toxic to human beings and their systems. And then once we know it's not a toxic product, then we can then try to evaluate its efficiency either as an immune booster or an antiviral agent or a cytokine storm inhibitor, whichever way it works, would then be subject to clinical trials. And then, if we can identify what the active components are, when you mix different herbal components together, you get a concoction. You don't actually know what is working. You still have to break it down into its separate components. Sometimes the components are synergistic. So a component will not work without another plant being present that boosts its activity. So, traditional medicine is very complex, but the most important thing is that we make sure that people who are receiving this concoction are not going to suffer any form of toxicity. Thank you.
Thank you very much, Professor Abayomi. Another question we have online, Dr. Coker, you help us with this. What the psychological and mental well-being for healthcare workers who are on the front line? This is the elephant in the room. No one is talking about it. For someone who's worked in the UK where this is a big deal, what experiences do you have to share with us, and what advices would you give? Dr. Coker, psychological consequences for healthcare workers.
So we're quite lucky in that we have a consultant psychiatrist. So we have a consultant psychiatrist that is attached to the isolation center, the OUTH. So that psychiatrist goes in to see the patients when on demand, and the psychiatrist is also available to the doctors should they need it. But more importantly, they have their leaders, their clinical leaders who have been supportive. They go in there and ensure that they are fine. I do go in every now and again to engage them and that we are supporting them and we are interested in their well-being as well.
Thank you very much. Last question that I have, Professor Abayomi, you take this. There seems to be a low incidence amongst children, even though several symptoms have been described in North America and Europe. What's been the experience of Lagos COVID-19 and children?
So we've had very limited experience. We had a mother and a child that were both positive. The child was only a neonate. We've had one or two young children or early teens. Generally speaking, when we see people within a cluster, that means a family unit where one person is positive and they've infected other members of the household. It's usually the middle-aged to elderly members of that household that have the symptoms. And the children who we know are positive, are asymptomatic. So I think we're generally following the trend, the global trend around COVID-19. And that is that the younger you are, the more resilient you are to the infection. The older you are, the more sensitive you are to the infection. So we haven't seen any pattern that deviates from that. Of course, if you have an underlying immunological disorder or you have some other comorbidities that would affect the manifestation of COVID-19 symptoms, that's a different kettle of fish. But so far, in a young healthy child or a young healthy teen, generally speaking, the symptoms are so mild that the individuals don't actually show any symptoms. Thank you.
So, Akin, as I hand over back to you, I don't know if Dr. Akin Abayomi from the Lafayette program is still online. I was told that they are providing technical support to states, and I know there are several partners online as well who are providing technical support to states. I think some of the lessons we've heard from our leaders today will probably go into some of the programs we are developing in the states we work in. As I said earlier on, I've learned a lot from this particular webinar, and I do hope that we have our scholars and academicians who are documenting this so that several of these innovative approaches can be taken to scale. Akin, once again, thank you to you and your team. I hand over back to you.
Olumide, thank you once again for your excellent moderation. And I want to also commend the ACIOE team. They have worked tirelessly. They have been going back and forth, but finally today is here, and they were able to get all our distinguished panelists here. I want to just honestly thank every single member of the ACIOE team. They've worked really, really hard. And like we said earlier on, I mean, this is a good opportunity, it's a good platform for us to really talk about the issues and get more insights on what's really happening on the ground than what we just hear on the news. And that's why I really thank all the commissioners who have taken the time out to do this. So on that note, I just wanted to say thank you once again to our distinguished panelists. Thank you to all of you who attended and participated in this panel. Thank you to our distinguished, even the principals that allowed you to be on this platform. They gave you permission to be on this platform. Thank you so much. And just want to thank everyone who participated. Thank you all, and have a wonderful evening and a safe evening. Please adhere by the NCDC rules, the WHO hygiene rules, and like I said, our next webinar, health webinar, will be on the 19th. So 2 Fridays from now of June. So have a really good evening, and God bless you all.
Thank you.